Good morning, everyone. We will start the session today. So today we have a special session as surgeons, especially as GI and HPP surgeons. We often deal with patients who have multiple comorbidities, and also sometimes because of systemic sepsis, these patients have multiple organ dysfunction. And in some patients, in the post-operative period, there is ventilatory failure. So in all these situations and many others, where we deal with critically ill patients, we require the help of intensivists or the specialists in critical care medicine department. And at the Mahatma Gandhi Medical College Hospital, Jaipur, we are very fortunate to have a very strong and supportive intensive care team, main member of which is Dr. Srishti Jain, who after obtaining medical education from the GS Medical College and KEM Hospital, went on to get her specialization in pulmonary medicine from PJ Medical College, Ahmedabad. And recently she did a 2-year fellowship training in intensive care and ECMO and heart and lung transplant at the University of Manchester in the UK. And I requested her to make a special presentation for our surgical students because all of us need to know the ABCD of intensive care.
Thank you so much, sir. It's a pleasure for me to be invited on such an esteemed platform, and it's echoing a lot now. मैं इसको तो बंद ही कर देते हैं, फ्लाइट मोड पे कर देते हैं।
नहीं, उसमें लॉगिन तो नहीं किया।
नहीं सर,
एक बार
मेरा म्यूट करूं क्या यहाँ पर? मैं अनम्यूट हो रही हूँ तो एको हो रहा है। सो या तो यहाँ पर अनम्यूट हो रहा है सर, आपके वाले कंप्यूटर में।
हाँ, हमने तो कर दिया।
आपने म्यूट कर दिया, फिर भी एको हो रहा है। हेलो,
ठीक है,
अब ठीक है। हाँ, ओके।
वो हमारा स्पीकर ऑन।
Okay. A very good morning to all of you. It's really a great opportunity for me to speak to all the surgeons. And as a critical care physician, trust me, we wait for this opportunity to talk to you all. So today, it's a very, very simple topic. We critical care people, since we have to work at a knee-jerk response, we try to keep things very simple. And today, it's all about our alphabets A, B, C, D, and E. So let's get the ball rolling. So I know we have earned a very bad name because you think that we intubate everyone who comes into the ICU. So, and we find it that it's the best way to fix anyone. Yes, we love it. So now, today our intention is that why as an intensivist, we love intubating the patients, and why our focus is that airway, breathing and circulation is our primary focus. And we stop you guys many times that hold on a second, don't touch the abdomen, don't touch anything. First, look at the vitals of the patient. First, look at the patient, whether he needs to be intubated or not. So I have a few residents sitting here. So I would ask one of you, let's start with, sorry, I'm forgetting your name, Vartika. So let's start with Vartika. Vartika, this is a 20-year-old male, and he has been just wheeled in to the ED 10 minutes ago. He was driving a motorbike, and he was inebriated under the influence of alcohol, and he had hit the post. And this is how he has been brought to the ED. So what do you think? What will be your approach? What are the first questions that arise in your mind after seeing this patient? Mode of injury, okay. Krishna, what do you think? What will be the first question that will come into your mind? Very nice. And Monil? Right, right. As a critical care physician, I wouldn't be bothered about the mode of the injury. I wouldn't be bothered about the circulation part, which you said, Monil. I will first go near the patient and I will assess for responsiveness. So what I will do first things first is that I will try to talk to the patient. Okay. So our objective of this today's 20-minute session is that we understand that there are many distracting things around in the ED. You will see a bleeding patient, you will see that the limb is cut and there is bleeding everywhere, but we have to be beware of these pitfalls. We have to focus on first things first. We also have to see the trend of the patient, right? Many times we see, oh, when I saw the patient in the ED, he was talking to me and now he is not talking to me. So trend is our friend. That is very important, and we have to be aware of the limitations of our own and those of our team. Early referral if the patient needs exceed your capability. Again, realizing that is very important. So situational awareness is very important. We got the thoughts of Vartika, Monil and Krishna sitting here, that how they will approach the patient, and let's unfold that how today's session will change our approach. So this is all what we will be studying about today. This is a famous protocol, that is the ABCDE, which is the part of the primary assessment and resuscitation. Then once we have made the patient stable and once we are satisfied with whatever way we have managed A, B, C, D and E, then only we will go for the secondary assessment and care, which involves the F, G, H, I and J. So let's keep the ball rolling. So let's start with ABCDE protocol, which is airway, breathing, circulation, dysfunction of the CNS, that is disability, and E is the exposure, that is the detailed meticulous clinical examination. So let's keep the things very simple here. Whenever we see any patient in the ED, first things first is you will go to the patient and you will talk to the patient. You can tap on the shoulder if you think that he is not conscious. First of all, call him by name. भैया भैया आपका नाम बताइए, आपका नाम क्या है, क्या हुआ आपको? मेरा नाम डॉक्टर सृष्टि है, मैं यहाँ इमरजेंसी में आपकी देखरेख करूंगी, प्लीज मुझसे बात करने की कोशिश करिए. If the patient is able to tell you his name, मेरा नाम, let's keep it Ramlal, we love the name Ramlal, Bollywood. So मेरा नाम रामलाल है, और अगर patient tells you his name, what does that tell you? So very good. Yes, that tells you that the patient's airway is patent. He's listening to you. He appears to be conscious. He's able to talk to you. And then the second question can be to assess whether how much aware he is or he's confused or not. The next question can be, क्या हुआ भैया, आपको क्यों आना पड़ा यहाँ पर अस्पताल में, क्या तकलीफ हो गई, आपको कुछ याद है? And if the patient tells you the whole narrative, कि मैं बाइक चला रहा था, मेरा एक्सीडेंट हो गया, that ensures you, okay, I have some time, I can go to the next step, right? So meanwhile, while you are assessing this, you will also tell one of your ED nurses that आप patient के vital monitoring लगा दो. So what vital monitoring do you want? What monitors, what things do you want from the monitor? Very nice. Yeah. Right. Right. So what will be your instructions to the nurse? What will you tell her? Turn on the monitor. Take the ECG leads. It can be a 5-para or a 3-para monitor. Stick the ECG electrodes. Most of the nurses would know where to stick the electrode. Otherwise, it is labeled on the ECG leads that are right side, left side, right lower, left lower, depending whether there are 5-para or a 3-para monitor, 3-lead monitor. So in that case, you will ask the nurse to attach the ECG leads, to put on the saturation probe, to tie the BP blood pressure cuff, tight enough so that you are not tight that you are not even able to insert your 2 fingers, and not loose so that you can insert your whole hand. So it should be the adequate tightness of the blood pressure cuff, which is very important, right? So meanwhile, you will ask your nurse to put on the monitor. So A, yes, what do you want? If the patient is able to talk to you normally, very nice. If he is alert and oriented, that is great. But when will you have a high inch of suspicion? If there is a change in voice, he is not able to talk to you. There is a strider, he's just not able to get the words out, or there is a noisy breathing, he can be snoring, or there can be a strider, there can be a trauma to the vocal cords, to the airway here. He can be dyspneic, he can be agitated. Many times you would see patients in the ED, they're so agitated, they're throwing out all the leads, monitor and everything. He can be extremely tachypneic. There can be an abnormal breathing pattern, right? And obviously, once you've attached all the monitors and all, you can see that the patient is showing a fall in SpO2, right? There is a low oxygen saturation. So look, listen and feel. So first things first, Bauji, आपका नाम बताइए, आपका नाम क्या है? Tap on his shoulders, ask his name, and then that should be your first assessment, and that is your airway. If there is any problem in the airway, will you go ahead and look at the wound? Will you go ahead and talk about the mechanism of injury? No. Yeah. Initial management of a threatened airway is very, very important. For example, we assess this patient and we see that something is there, there is a lot of blood coming out from the mouth. What I will do is suction. So I'll request my nurse to put the anchor suction, give me the anchor suction, put the suction machine on, put at a pressure of around 120, 130. We don't want a lot of vacuum in the suction machine. Why? Because it can then cause trauma to the oral mucosa. We don't know what's happening around there. He might be an alcoholic liver disease patient, as in your case, and there might be a possibility that patient is having oral bleed because of the coagulopathy, right? In your case, it is again very, very important. So airway clearance, you will do the vacuum suction. If there is a stridor, what can you do is, some of you have done your ACLS, BLS and the ATLS training. So if there is a stridor, what will you do? Jaw thrust and chin lift. If you are suspecting a cervical spine injury, we will limit ourselves to jaw thrust. We will not do the head tilt and the chin lift. If that works, what we can do is, we can put a oropharyngeal airway or a nasopharyngeal airway, and we will apply oxygen. We will apply the maximum oxygen because we are not sure how much of severity we are dealing. So we will apply a bag mask. Okay, that's the face mask which has a rebreathing bag below, and we will increase the oxygen to 15 liters per minute. That will help us in applying 100% oxygen to our patient, right? So that's the oral airway we all know about, and we will insert the oral airway to the patient. So we are trying to make sure that we have secured our airway, right? But of course, things can be even worse, and we might need to intubate the patient upfront, right? If he's desaturating, oxygen has also not helped, and there is a stridor which is very bad. He's not able to open his mouth. There is a problem with the wounds, or there might be burns. In a burns patient, we immediately want to intubate the patient, because once there will be swelling, trust me, it's a disaster. So if there is a burns patient, we don't wait, we intubate immediately upfront, right? So respiratory rate, then you will look for the breathing. So B stands for breathing. We will look for the respiratory rate. If the respiratory rate is more than 20, it is a cause of concern. If he is tachypneic, 20 per minute is one of the parameters of the SIRS criteria, that is systemic inflammatory response syndrome criteria. And if the respiratory rate, on the other hand side, if he is very bradypneic, he's not breathing, that means he could be narcotized, right? He might be under the influence of alcohol, not just alcohol, but some other opioid drugs or other drugs. We don't know. New Year is coming close, so we don't know what could be the reason for the low respiratory rate. Again, we discussed about this. Caution: cervical arthritis. Older patients may also have loose teeth or may have dentures. We have to be very, very sure. It has happened many a times that when you are new, you're enthusiastic, you have not done the proper sedation, you're not given the patient proper sedation and neuroparalytic agent, and you put the laryngoscope and you break 3 or 4 teeth, and he's an old patient, he had loose teeth. So it is extremely important to be cautious about that. And patient might be on steroids or might have a very poor nutritional status. There might be nasopharyngeal mucosal fragility. So we have to be a bit cautious with that. So indications of definitive airway, when you are sure that you have to definitely secure the airway before you move further ahead, is if the patient is apneic, is not breathing at all, he's not able to protect the airway, continuous bleeding from the mouth, or the airway is fine, but the ventilation is not adequate. Okay, he's bradypneic, he's not breathing, he looks narcotized. Please intubate the patient upfront. Three components of the definitive airway. You place the endotracheal tube below the vocal cords with a low pressure cuff. Endotracheal intubation or nasotracheal or tracheostomy connected to the oxygen, and you are sure that you have secured the airway. If the patient is in ED or ICU, you have the end-tidal carbon dioxide monitoring devices with which you can make sure that endotracheal tube is placed at the right position. Or if the patient is on ventilatory support, the ventilatory graphics help you to tell that a tube is positioned at the right position, right? So endotracheal intubation to discuss in this small session, but we will just touch the points that we will pre-oxygenate the patient with 100% oxygen. Take a deep breath yourself. Things may go wrong. And I would say that when you are in ED and when you are a beginner, always make sure that let the senior consultant anesthetist be aware that you are intubating the patient. Let him stand at the bedside, not to make you afraid or not to make you lose your confidence, but to make sure that if you fail 2 attempts, you are not getting the 3rd attempt. Let the senior person intubate, right? If you cannot intubate before you need to breathe, stop and use the ambu bag and mask again. Visualize the cord, watch the chest and auscultate, put the ETCO2 monitor on, and put the pulse oximetry on. Limitations of pulse oximetry. Low oxygen saturation of 93% or less is a late sign. 93% oxygen saturation on pulse oximetry, if correctly measured, means that the PaO2 is 60 in the arterial blood. And what could be the other limitations of pulse oximetry? Yes. Right. Yes, you're right. Yes. You never know what was the mechanism of injury. So methemoglobinemia could be a possibility. Anything else? Very nice. So if the extremities are cold, patient is extremely hypotensive, the perfusion is very bad, you might not be able to get the pulse oximetry readings, right? So occult airway injury, sometimes it may happen that you may just put the oxygen on and you may move ahead with your assessment of B, C, D and E. If there is an occult airway injury or you are not able to judge whether if there is a progressive loss of injury, is bleeding and bleeding and bleeding somewhere near the vocal cord, somewhere near the oropharynx, and then there is a big clot which suddenly blocks your airway, or there is an equipment failure, which can happen, or there is an inability to intubate. All these are known problems, but again, with time and with a senior guide around, you may be able to reduce the chances of these mishaps as much as possible. So coming to the breathing, we will look, listen and feel. We will see that the trachea is in the center, right? So if you come from your ventrum below, this is the trachea and the tracheal rings, and you can use your 3 fingers. So like this, you're moving your middle finger on the trachea, your rest of the 2 fingers are on the sternocleidomastoid muscle, and once you move your finger, you will come to know that whether the patient's trachea is in the center or not. Why is it important to check for the tracheal position? Yes, absolutely. So in the case of the pneumothorax, the trachea will be shifted towards the opposite side, right? Neck veins empty or there is raised JVP. Why do you want to see the neck veins in breathing? There could be cardiac tamponade in which you can see the neck veins which are engorged. What else? Tension pneumothorax. Yes. So tension pneumothorax, you can see that the neck veins are engorged, right? What else? What if you don't see the neck veins? They are absolutely collapsed. Hypotension, hemorrhagic shock. That could be the possibility. So you will look at the neck veins. You will look for the chest expansion. Now presume that you have intubated this patient, you have secured him, he's stuck on the ventilator. Now you're doing a breathing assessment. You see that one side of the chest is not expanding. He's not able to, there is no expansion on one side. So what will that tell you? That's a very nice point. But when I am intubating, I will make sure that my cuff goes just below the vocal cord. Very true, Vartika. That can be one of the possibilities. It happens when we are, overzealous intubators. We have done this in our new days of critical care era, where we would put the tube too much inside and that would go into the right main bronchus. Yes, that could be one of the possibilities. What are the other differentials? Again, pneumothorax, you might see that the lung is not expanding on that side, or a hemothorax, or a lung collapse. In all these three cases, you would see that the chest is not expanding. Then you will percuss. So on percussion, what note the pneumothorax will give us? A hyperresonant note. And the hemothorax, a dull note. A collapse, a dull note, right? So you will listen to the percussion note, then you will auscultate. So if you are seeing that there are bilateral crepitations, think about lung contusion, right? Lot of chest injury, rib fractures, or if there is wheezing, you never know whether the patient was a known asthmatic, and it has happened so many times that in the post-op management of the patient, we see in the ICU that we are not able to wean off the patient, and then when we auscultate, we find that there are bronchi, and then we take the history, we come to know, oh, he's a chronic smoker, he's a COPD. So these patients, they are extremely challenging to manage when put on a ventilatory support. Tension pneumothorax, yes, following trauma or a central line insertion, and positive pressure ventilation. So again, this is very important. Sometimes it happens that before the intubation, saturation was, let's say, 90%. But once you've intubated, the saturation keeps on falling. The neck veins are engorged. The chest is not moving. And then you think, oh my God, this is the tension pneumothorax. And while you're ventilating the patient, you're worsening that situation, isn't it? So, needle decompression, where will we put the needle? Second intercostal space. Let's keep the thing simple. Pneumothorax, sky earth axis, air will come to the front, fluid will go to the back, sky, earth. So you will put the needle in the second intercostal space, and then you will ask the nurse meanwhile to get ready for the intercostal drainage too. Very, very important. You have to manage the tension pneumothorax there and then. You don't move to the circulation.
Air and fluid. Air, anterior apical. Put the needle drain, and B, blood, base, behind.
Wow, that's very nice. I got to learn something new. Thank you, sir. So yes, that's an amazing way to remember this. Then once you are satisfied with your breathing, once you have made sure that your lungs are expanding bilaterally, there is no red flag in the neck or in the chest, then we will move ahead to what we discussed before is circulation. So circulation, how will we start our circulation assessment? Yes, so I will touch the patient. I have initially touched the patient Ramlalji on the shoulder. Now I will hold his hand. I will see how are the extremities, how are the legs. I will, take his shoes and socks off. And trust me, before airway, I'm not gonna uncover him. I'm not gonna ask the nurse to remove his clothes and everything. I will do first things first, and then I will see the legs. I will see the foot, and I will see, oh God, what's this color of the skin? Whether he's cynosed, whether there are cold, clammy extremities. Then I will look what's the level of the consciousness. If I have intubated, obviously I presume that we have sedated the patient. But if he's just on oxygen support, you are happy with the breathing, then you will ask again, try to make a communication, because that will tell you the level of the consciousness. You will also see the pulse rate, right? And the character, whether the pulse is nicely bounding or whether it's a feeble, thready pulse. If there are drains, for example, in a post-op patient, look for the drains. Drains do get blocked. Sometimes post-op patients, you have seen so many times that abdomen is distended, is not able to breathe properly. You think there are no drains, blood pressure is dropping, and then one of you comes and you readjust the drain and you see, oh, the drain was blocked. Blood on the floor and pour more. So this is very, very important. Again, if there is a patient in the ED wheeled in and you see that there is blood on the floor, that means 4 more. There can be 4 times you can expect that the patient can go into hemorrhagic shock or is already into a hemorrhagic shock. So once you've secured your airway and breathing, then your aim is to stop the bleeding. You will put a compression bandage if there is a bleeding from an extremity. Pelvic fractures, very, very bad. Sometimes you don't see them, but your patient is in shock, and then you have to call your orthopedic colleagues, help them, take their help to fix the pelvis, or there can be a femur fracture or any other long bone fracture. You need to stop the bleeding. You establish adequate venous access to large vein flon. If your patient needed intubation, you would have put the vein flon much earlier in the series. But if your oxygen, just your oxygen would have helped, then now is the time to put a vein flon. So you'll put a 2 large bore IV cannula. Will you put a central line first or a vein flon first? Why? Yes, very nice. So short length, wide bore, and that's why you're able to give fluids much more quickly with a wide bore IV cannula rather than a central line. Yes, you do need central line. Once you have secured your IV cannulas, you've started the fluids, but you expect that the patient can go in shock and you need NORAD support or a vasopressin support. In that case, you will make yourself ready to secure the central line. You will take the blood samples, you will send for blood group, cross-matching, and the routine examinations which you want to send. You will administer a fluid bolus of 10 to 20 ml per kg crystalloid, and you will repeat the fluid challenge as necessary. Frank-Starling curve in action. So, can anyone tell what's Frank-Starling curve? It all means is that initially when you are giving the fluids, your blood pressure will respond. But there will be a time, one time will come when your patient is no more responding to the fluid support and the fluid might be leaking into the lungs. So again, in modern critical care, there is a magic in our tool, magic in our hands, and that is the ultrasound machine. So we can always do the focus ultrasound, focus echo, look for the LV contractility, look for the IVC filling, and hence indirectly determine that whether my fluid resuscitation is adequate or not, right? But again, first things first, you need to stop the bleeding. Then once you are happy with your circulation, your nurse tells you saturation 100%, heart rate of 100, blood pressure 120/80. The next step to go to is disability and dextrose and drugs. So there are 3 Ds in the D segment for the disability. So you look for the GCS. Minimum is 3. What are the components of GCS? Okay. So is GCS important to a surgeon? Yes, right? For a GI surgeon as well. Because if you are handling a patient of trauma, you never know whether what are the other injuries that are going on with the patient. So if you find any problem with the GCS and if you have to wheel the patient to the CT scan for the CT scan, so you want your head CT. At the same time, always for a trauma patient, you also want the screening of the cervical spine. And then nowadays in big centers, you go for a trauma whole body CT scan. You go from head till the abdomen because you don't want to take multiple attempts and waste your time. So any obvious focal, motor or sensory neurological deficit is a red flag. You look for the pupils, you look for the size, symmetry, and the reaction to the light. This is
this whole body CT is a part of trauma recommendation, cost and affordability.
so no, I would still say that not in our Indian settings. While I was working in Manchester, yes, trauma CT, they had a trauma code, and as soon as the patient would come to the ED after the A, B, C, D, E, immediately wheeling for the CT scan, they would do the head to abdomen whole body CT scan. They had this low dose LD CT, making sure that the radiological exposure is not very much, but then they did it every time. So this is a picture of my teacher, Dr. Ajay Sharma. He is a renal transplant surgeon in Liverpool. I happened to meet him 4 years ago in India when he had come to teach for a course. Wonderful person. And he is the one who has actually prepared these slides for training of the surgeons at critical care. He runs this course, ACC, everywhere. And
He was
so this is a picture of a resource limited hospital. As we can see that we are using the light of the laryngoscope to see the pupils. It's just an example that whenever you want to create possibilities and do good service to your patients, you can find ways out, right? There, you will find endless reasons to complain that this is the problem in the ED, this is the problem in the ICU, but you will find 1 million reasons to find a solution if you want to.
But this is
Yes, sir. Once upon a time in medical college.
too extreme.
I think COVID was one era which taught us to become resilient, to hold our nerves, and to work in any condition possible. Anand, Monil, Krishna, most of you have worked with us during the COVID times, and you all know that what was the situation. Like, we couldn't complain. True, sir.
We did not have a life. We did not have a quarterly, we have only life.
True.
We did not have
True. And I think all over the world, everyone now realizes that we managed the COVID with, I mean, I will not compare, but with the number of the patients we had and the number of the doctors we had, I think we gave more than 110% best than any other country could have given. I saw the first wave in the UK. I saw the second wave in the India, and I had so many thoughts to share that how they would just keep on complaining, oh, we don't have veg, we don't have this, we don't have that. And on the contrary, here we were not thinking left, we were not thinking right, we were increasing the number of the ICUs and the beds every day. All right, okay, we are not able to give the best of the critical care, but we can give oxygen. We can give whatever we can. So,
violent injury. Is it COVID taught Indians the mass, how to eat the mass casualties?
true.
You know, it's a very common thing in armed forces. They have a drill because it starts in the war, na, and they have a echelon.
I think we will go a bit quick on the Glasgow Coma scale. We all know how to assess the best motor response. We all know how to assess the best verbal response and the eye opening. So on these three criteria, we will scale the patient on the Glasgow Coma scale. Then the other D after the GCS is the dextrose. It is very, very important to check for the levels of the sugars. We forget it so many times. And that's why, as I said in the beginning, in critical care, we need knee-jerk responses. And that is why we have made so many mnemonics. So D is for disability, dextrose, and drugs. So dextrose, please check the blood sugar immediately. If there is any altered sensorium or if even there isn't, and if you see that the patient is hypoglycemic, please give 10% dextrose, 5% dextrose, DNS, whatever is available in the ED if you find the sugar less than 70. Drugs, important drugs affecting the ABCD. Yes, do you want to know the history? Whether the patient took any medications or if he's under the influence of some morphine or he took some oral hypoglycemic agent, he took metformin or glimepiride and then he was driving and then you see the sugars are not coming up and then the wife tells you, oh, these are the medications he was taking. She comes after 2 hours. So we need to know about the history of the medications. If omission of insulin or oral hypoglycemic, patient can land up into ketosis. Omission of salbutamol or any anticoagulation or any antiplatelets. He might keep on bleeding. You might keep on giving just blood and fluids, and then you might realize, oh my God, he was on warfarin. I needed to give FFP or the PCC, that is prothrombin complex concentrate. Then finally, we will come to the exposure. We will expose the whole body. We will ensure privacy and dignity of the patient. We will protect the patient against hypothermia. Like once we have uncovered, we will put the blankets on, we will put the hospital clothes on. We will look for any obvious bleeding, hematoma or signs of inflammation. We will check all the wounds now. We will look for any distension of abdomen or swelling of legs or as an evidence of GVG. So next time when Krishna and Monal would be called to the ED, they will make sure that have you done your A, B, C, D, E? Then only I will jump to the abdomen, right? So let's review our A, B, C, D, E. So we have organized our thoughts at this stage. We've ensured that monitoring of ABC is instituted. We review the effect of all the resuscitation, right? We will not go to the abdomen if the patient is still hypotensive. I would keep on giving the fluids. I will wait for the blood to come. I will quickly do a blood gas. I will see what's the hemoglobin. I will see what are the other problems. So I will review my resuscitation till I'm happy with all my A, B, C, D, E. Then I will also decide whether he needs to be shifted to the theatre or to the ICU. Only after the patient is stabilized, then is the time to move to the secondary assessment.
Just one more. At this stage, you have done this ABC and you find that in a case of polytrauma, and the CNS component is the prime one to see, and you have been called to see the patient, and patient is now the CNS hemorrhage never is that much to cause hypovolemia once patient has been taken control of. You must look for the other cause of the patient is bleeding somewhere else, not in the CNS.
So true, sir.
Yeah.
I think in the last month, we saw 2 patients with pelvic fracture, crushed pelvic injury, hypotensive. Orthopedicians come and they are like, nothing, there's nothing to do. And then you wheel in the patient for all the x-rays and everything. I think we waste a lot of time. X-ray, AP, X-ray this, and the 5 hours, 5 hours, 6 hours are wasted in the ED just to convince the orthopedic surgeons that, you know, there's a pelvic fracture and we need to do something about it. So absolutely true, sir. We need to look for the hidden sources of bleeding. So that's the primary assessment and resuscitation. This should be imprinted in your minds by now. Airway, breathing, circulation, disability, dextrose and drugs, and the exposure. And then we will go to the secondary assessment and the care. So what are the components of the secondary assessment? That is F for fever, fluid, Foley's. कितना simple बना दिया ना? Fever, fluid and Foley's. G for gastric tube and other tubes. H for now you will come to the history and detailed head to toe examination. I for investigations and J for judgment. And again, trend is the friend. You will keep on reviewing your A, B, C, D and E. If there is any deterioration, you will again leave the secondary assessment and you will jump to the primary assessment. So
this is this A to J is what
it's an extremely standard protocol, sir.
No, who devised this A to J? A to E we knew. It started with A to C, then B came.
So ATLS.
Up to J is added in ATLS.
Up to J has been mentioned in ATLS, but if you can see there, ACCC, this AIMS Critical Care Course, and again, Dr. Rajesh Sharma, he is the one.
So you can add another one, you can add K.
Okay.
K for counseling.
Alright, sir. True, sir. True.
K for, once you have done all this, then counseling of relatives is very important.
Absolutely, sir. So this is a chart which we can stick in our EDs, in our wards or wherever we happen to see the critically ill patients. If you see the ICU daily note sheets, we have devised it in the A, B, C, D, E, F, G, H, I, J, K format only. And in the, as sir said, there is a column of communication in the end, which we try our best to document and take the family's signature. So this is just a, you know, sheet, a cheat sheet which we can stick in our wards and ICUs and EDs. So we are very optimistic people. We are pathologically optimistic people. And I think we laugh the most. We never accept that, patient is dead. Mostly dead is slightly alive. That's what how we think. And I think as a critical care physician, we have to keep our spirits alive, and then only we can keep going. So let's come to our F, fluids, Foley's and fever. So you assess the input, urine output and also the drain output. You see for the Foley's, indwelling urinary catheter is inserted because you want to monitor the urine output. It will tell you so many things. So modern day critical care, hashtag 2021 is the era of EGDT, that is early goal directed therapy. And goal directed therapy means you don't just calculate, okay, 30 ml per kg, itna de dena hai. No, you look for the urine output, you look for the blood pressure, you look for the response, you look at the graph of the pulse oximetry, plethysmograph, you look for the variation, pulse pressure variation. There are so many things in the assessment. Then temperature chart is checked to look for fever or hypothermia. So this is a very common observation in the surgical ICU. That patient comes from theater, nurse tells you he's in bradycardia. We say, okay, temperature probe lagao, 32 degrees Celsius pe mareez milta hai. Then you put the warmer and everything, and the bradycardia is treated. So many times patient don't need atropine. They need the temperature to be checked, right? We have seen Osborne J waves in surgical ICU. I think it is the coldest room in the whole hospital, I believe. So yes, you can see Osborne J waves in those hypothermic patients in the ECG. Then you take the history, then you do the head-to-toe examination. So detailed head-to-toe examination. So what was the indication of the surgery? If it's a post-op patient, comorbidities, assess all the wounds, the stomas. You do the frequent and repeated clinical reassessment, and always remember, trend is the friend. Then you put the gastric tube for decompression, for diagnosis and treatment. For example, if the patient is having abdominal distension, hematomasis, melena, they will need gastric tube for diagnostic and therapeutic purposes. Sometimes we do give cold saline lavage in a bleeding patient having hematomasis while we are waiting for the surgical review, so that can help in controlling the hemorrhage. Look for all the tubes and the drains, and always look for the operation notes if this is a post-op patient. For example, if this is a post-op patient who deteriorated in the ward and then was wheeled into the ICU after a code blue, let's look into the OT notes and let's think what could go wrong. In the history and head-to-toe examination, the notes, OT notes, asking the patient, asking the ward nurse, asking the family will tell you a lot of things. You take the ample history. So again, another mnemonic. As I said, we just love mnemonics. So ample history, A for allergies, M for medication, to review the detailed list of medications. Trust me, we have landed into so many problems in the post-op ICU just because we didn't look into the pre-op medication chart, that what was the patient taking regularly. Glimepiride 2 gram, the patient will not come out of hypoglycemia for 1 full day. एंड देन यू आर स्ट्रगलिंग D25 दे दिया, फिर भी शुगर नहीं बढ़ रहा, फिर 1 घंटे बाद फिर हाइपोग्लाइसीमिया हो जाता है, फिर हिस्ट्री का पता चलता है कि पेशेंट ने मेडिकेशन ही बंद नहीं किए थे, या ब्लीडिंग नहीं रुक रहा है, पता चल रहा है एस्पिरिन पर था, क्लोपिडोग्रेल पर था, वार्फरिन पर था. So history is very, very, very important. Last month, it's a simple patient after this oromaxillofacial surgery. Second day after intubation, he's sitting and everything, and then he seizes. And we don't know what is happening. We stand on the head and we are ready to intubate. Thank God the relative came in. He said, "Oh, he's seizing again." He's like, "Again? What do you mean by saying again?" He's like, "Oh, he seized last month. We started him on some medication, but then he doesn't take only." Then we come to know that he brings a theli. In that there is carbamazepine, there is eptoin, and thank God we didn't intubate that patient. We just turned him to the right side. We had put a bite block, put him on oxygen, and after some time he became conscious. He said, "Oh, I stopped the medication. Doctor told me to stop all the medications before 1 week of the surgery." It happens. It happens. So we don't stop anti-epileptics, right? If we stop the oral hypoglycemic agent, we call my esteemed husband pre-op, not just post-op.
The word has been recorded.
Thank you, sir. So So history is very, very important, and we have landed up in trouble if we have not reviewed the notes, OT notes, and the anesthetic notes. Then present and past illnesses. I have to share this example. I can't stop myself. 2017, it was my second year in MGH. I joined MGH in 2015. We get the renal donors for one day in the ICU. They're just for observation. They sit, eat, and go out the next day. This patient, he's a renal donor. He donated his kidneys to his daughter. And first hour post-op, he's fine. 6 hours, he's fine. But we see that the drain amount has increased. 100 ml empty किया, फिर 100 ml empty किया. Renal donor में कभी ऐसा नहीं होता है. शाम को 6 बजे सिस्टर बताती है कि 600 ml empty कर चुके हैं ड्रेन. And then I come on that night shift at 4 o'clock. ड्रेन खाली कर दिया. गुदारा सर को फोन किया. सर ये तो ब्लीडिंग ही बंद नहीं हो रही. ट्रेनेक्सा 1 ग्राम लगा दिया. उन्होंने ओटी में ले गए दोबारा. पूरी सदासुखी सर आ गए, सब आ गए. एंड देन पेशेंट इज व्हील्ड इनटू द थिएटर अगेन. सब कुछ कहते हैं वो ब्लीडर था, हमने बंद कर दिया, पैक कर दिया, कुछ नहीं होगा. रात को 3 बजे फिर से ड्रेन भरना चालू. फिर पेशेंट थिएटर में जाता है, फिर वो पैक लगा के वहीं थिएटर में रखते हैं, वहीं पे बैठे रहते हैं. सुबह 9 बजे पेशेंट वापस आता है. तीसरी बार फिर ओटी जाता है. फिर उसके प्री ऑप नोट्स, मैं और आशीष सर बैठते हैं, सर कुछ तो झोल है. प्री ऑप नोट्स, वी ओपन हिज पुराना पूरा वर्कअप का हिस्ट्री फॉर द डोनर इवैल्यूएशन. APTT 81, APTT 90, APTT 83 in 3 reports. Isolated APTT. He was suffering from a hemoglobinopathy. He had factor 8 deficiency. वो सब इवैल्यूएशन तीसरी बार ओटी में से आके हुआ. बाद में वो बताता है जब वो किसी तरह फैक्टर 7 मंगाया, क्या क्या मंगाया, पूरा हॉस्पिटल ने उसका खर्चा बेयर किया. 25 लाख तक हो गया था बिल 2017. एंड देन ही टेल्स कि मेरी पहले भी एक सर्जरी हुई थी, तब भी मेरी ब्लीडिंग नहीं रुकी थी और बहुत परेशान हुए थे सर्जन्स. कितने दिन मुझे हॉस्पिटल में रखा, कितने फैक्टर्स दिए, मुझे पता था, बट आई वांटेड टू सेव माय डॉटर्स लाइफ. आई डिडंट टेल एनीवन. I can never forget that incident.
Almost similar story. I had a previous PVT. Several doctors of the
So this can happen. We need to see our pre-op reports.
And the worst thing in these type of cases is that it's not always, theory is all right, but it's not very easy to diagnose it. It happened with me. I was a GI surgeon, and a new surgeon has come to in Lucknow, and he said, "Sir, मैं अभी लैब खोली नहीं सर, मैं ओपन करता हूँ, ठीक है, I will assist you." I probably am not doing anything, so I assisted him. I was assisting in the case, nothing, everything went all right. Patient in the evening we came, took a round, no problem. In the night I got a call at 2 o'clock. सर पेशेंट के सर ड्रेन में सर पूरा ब्लड भर गया है. मैं फटाफट आई जस्ट रीच हॉस्पिटल 5 मिनट्स ड्रोव टू द हॉस्पिटल. पूरा वो लकीली द अदर सर्जन आल्सो आई वो पूरी मैच में ही रहता, वो वेंट देयर. आई डिडंट हैव एनी ऑप्शन. पेशेंट वाज वर्किंग, मैंने उनको ओटी में लिया. ओटी वाज वेरी क्लोज. तो खोला एंड वी डिडंट फाइंड कहीं उसके कोई ब्लीडिंग नहीं. And that patient was all right. उसका अटेंडेंट कहीं चला गया. हस्बैंड was lady, she was lady. उसको मैंने हस्बैंड को बुलाया. मैंने कहा कि मर जाएगी, मतलब मर गई तो रात में तो बड़ा खतरा होगा, फिर आपको तो देख कर गया है. उसे बुलाया, वो आया, हमने बंद कर दिया एकदम. Then he tells me, से बात कर रहे थे, साहब ये तो मेरी मैडम को तो पहले ही एक बार मैं उनके वो हुआ था, उसका अंदर ऐसे ही हुआ था. Like I felt like hitting him. Same thing, but we investigated, but we didn't find any reason. But obviously, it must be one of the bleeding practices.
Tendencies,
But
yeah.
the diagnosis of these things are very different.
Yeah, but you cannot pass on the blame to the patient.
True.
He didn't tell me.
True.
Blame is yours.
Yeah, I agree with you. Yeah, I agree with you.
We always do the pre-op workup, and I think we ignored that APTT of 8193 reports, 3 reports. So we didn't look into it seriously. Then coming to the last meal, to decide about the anesthesia if the patient needs an operation. So we need to know the history of the last meal. Review of the sequence of events. So what happened? We need to know the chain of the events. So that's the ample history. So allergies, medication, past and present illness, last meal, and events. So that's how we remember the ample history. Then I for the investigations. Yeah. It's almost over, sir. So investigations, available results first. Sometimes you might see that the patient has brought the reports from some other hospital. Targeted, not blind. Trend of the result is more informative than a single value. Hematology, you need to see the hemoglobin, TLC, DLC, and coax screen. You need to see the biochemistry. Important things are blood glucose, ABGs, LFTs, RFTs, and pregnancy test if she's a female. And the microbiology reports and radiology reports and the film review. So that is for the eye.
Pregnancy test again is very important. There are examples in every hospital where early pregnancy they have been subjected to CT scan. Every female in the age group, your record must mention out.
An ectopic pregnancy can be one of the reasons for shock.
Yes, in emergency, but this is inexcusable to have CT scan and for the rest of
True.
The field is very, I mean, you have to justify it.
And consent.
You have to justify it. Consent, field, everything. But pre-operative workers, you know,
True.
Actually, the pre-op test X-ray is also coming under a lot of scrutiny now. There are a lot of reports which say that if the patient has no symptoms and clinically normal, test X-ray needs at least in the West.
That ASA guidelines do not they are now going back to like that ER protocol and this thing.
No, so the
same thing. They are not asking for too many investigations. Huh? No. You just see like surgeons of our era, ECG and in armed forces, it was a thing that till age of 45 you are asking any fellow, the fellow is this thing. And his physical status is not giving you any history of dyspnea, this thing. He doesn't give you any history of chest pain. Why you are getting X-ray chest and ECG done?
So finally, we come to the J, the judgment time. That's the D time. So decide if the patient is stable or unstable. Definitive treatment. Discuss with your own registrar or consultant, your own team, and to other specialties. Always do an MDT, that is multidisciplinary team discussion. There is no time to call the consultant. If you are in doubt, call the consultant anytime. Define, commence, and implement. Make sure what's the correct level of the care that's needed for the patient. An unstable patient requiring frequent monitoring would require ICU or an IPU.
Very important for they know what time to call it. Whenever in doubt, whether it is midnight, whether it is Sunday or weekday, whatever, do not hesitate to call us. No consultant will kind of reprimand you for calling at an odd time. If you don't call and commit a mistake, then we will be.
True.
There has to be a reason.
There has to be a reason. We have a mnemonic for that, ISBAR. ISBAR. That is the mnemonic of calling. How do you talk to the consultant on phone? I'll share later if time permits. So then you have to make your notes for recording all the plans and to check the progress. And then as Sir said, you have to communicate. So hashtag 2021, document what you communicate what you document. So it is very, very important. See, trust me, now in the 21st century, गधे और घोड़े बीच में आ जाएंगे, है ना? प्रोटोकॉल्स होंगे, SOPs होंगे, सब कुछ सबको पता होगा क्या करना है. एक अच्छे और बुरे डॉक्टर में जो डिफरेंस क्रिएट करेगा वो होगा आपके कम्युनिकेशन स्किल्स, आपके टीम मैनेजमेंट स्किल्स, आपके लीडर स्किल्स, आप कैसे अपनी टीम को, नर्सेस को वार्ड बॉय तक को उस इंटेंशन में मोटिवेटेड रखते हो कि वो पेशेंट को अच्छे से लुक आफ्टर करें, एंड फॉर दैट यू हैव टू लुक आफ्टर देम, right? So good communication, healthy communication is very, very important. So that's the end of this session. I would love to have any questions if you want.
You said that if people know, then so the initial research thing, the research is always normal saline or regular. It's not this.
No, sir. It would be a balanced salt solution like a ringer lactate or sterofundin or plasmalite, cabilite.
Another question, I don't know whether you can answer or they would know. You want them once or next come to be exposed to this theoretical knowledge, so they should be doing it. So CPM is not the place because it is usually not done in the city, than the emergency department. How many such emergency do we get, say, in a month? Who they are there? How many such do they use?
So we do a 2-day course, this ACCC course. I'm one of the faculty members in this course.
Would be real life.
So, अच्छा इनका ED में posting लगे हैं. I get it.
एक महीने के लिए पोस्ट हो तो कितने ऐसे आएंगे जिसमें
सर बहुत आएंगे सर. अपना ED is very busy सर. बहुत आते हैं सर. ट्रॉमा बहुत आता है. बहुत केसेस आते हैं. नहीं सर काफी आते हैं सर. नहीं नहीं काफी आते हैं.
जो बंदा इधर से नहीं, जो बंदा इधर से आता है ना, उसके लिए तो लगता है कि मेरा पेशेंट गया तो ही को डजन
यस सर. नो सर. सर कोविड के बाद से हो नहीं पाया.
and now we just see now it is mandatory for each student. Yeah, this student, all MBBS student, in that initial 25 days, this ATLS is a part of it.
True sir.
Yeah, in that 25 days.
True, sir.
next course when you conduct after
Sir, we are doing in January.
Okay.
So now we will be doing ATLS course every 2 months. जनवरी में होगा, फिर अप्रैल में होगा. Sir, I will keep sending you the flyers. So 17,500 rupees because it's American trauma surgeons have endorsed this course. Yes, ATLS, American Trauma Life.
It is for all from the day your admission is done, 1 month there is nothing.
No, if it is not here, then I will send them to the
सर यहाँ पर बहुत है सर.
दो दिन छोड़ देंगे एनाटॉमी हो जाएगा.
So what Ajay sir was asking that how do you talk on phone? So we have a mnemonic that is the ISBAR mnemonic. So how do I share this? हाँ सर क्योंकि हमें तो नीचे से काम करना होता है ना. अच्छा. Okay. So this is the standard how to talk on phone mnemonic using the ISBAR handover tool. So it is for the junior medical officers and it's a wonderful tool. We love this. So identity of the patient. So name, age, MR and ward. So I'll just give an example. Like for example, I'm calling Dr. Anand. I am his junior resident and I'm on duty in the ICU and a patient has deteriorated. So hello Dr. Anand, I'm Srishti. I'm the junior resident on duty. I have something urgent to talk to you. So you alert him in the beginning itself. क्या पता वो सो रहा हो, नींद में हो या कहीं busy हो. So I have something urgent to talk to you. I want you to be made alert about a patient named Ramlal, age 53, who got admitted to the ICU at 4 o'clock in the evening. He is admitted under the team critical care, but he's having a gastrointestinal problem, which I think it is very urgent to be dealt with. So I have made him alert that Anand, this is something serious, ud jao. Then situation. So symptom and the problem. So this patient is complaining of very severe abdominal pain, and he's not even letting me touch the problem. The patient's patient stability. His ABCDE has been taken care of. He's stable. The level of concern is his abdominal pain, which is extremely severe. I will give you the background. This patient got admitted under us after he had a road traffic accident. He got admitted at 4 o'clock. This is the diagnosis. In the past medical history, he had a history of polycystic tummy done 2 weeks ago. He was on just simple antibiotics and painkillers. And then I will tell Anand my assessment and action. I think that he has a ruptured bowel. I have called the radiology resident to come for an urgent ultrasound of the abdomen. I have given him tramadol and a pantoprazole injection. I have also asked my anesthetic colleague to give him a local block if it's possible. Then you told about the response, what you want done, treatment, investigation underway or that need monitoring, review by whom, when and what, and plan depending upon results or the clinical course. So response and rationale, Anand will tell me, Srishti, thank you for alerting me. It's okay if you have called me in the middle of the night. I understand your concern. I want you to wheel him for the urgent CT scan, ensuring that his ABCD is secured. Please give him this and that. I'm coming in 10 minutes. Meanwhile, I come. If the CT scan films are available, please WhatsApp me and call me again. How did that conversation go? So Ajay sir will be alerted that Vartika is calling for some reason which is damn serious, right? So that is the ISBAR. Identity, situation, background, assessment and response, right? And we have another mnemonic. We love this mnemonic also. Fast hugs BID. So अगर patient hospital में already ICU में admit है और आपको उसका daily assessment करना है, तो आप कैसे करोगे? Feeding, analgesia, sedation, thromboembolic prophylaxis, head of the bed and elevation. Shall I just enlarge this? I'm sorry. Can we see? So feeding, analgesia, sedation, thromboembolic prophylaxis, hugs, head of the bed and elevation, also prophylaxis, glucose monitoring. S for spontaneous breathing trial. अगर patient ventilator पर है तो daily उसको spontaneous breathing trial देना है. V for bowel care, bowel opening हुआ कि नहीं. I look for all the indwelling lines, tubes and catheters. कभी भी ICU से ward में shift करते हैं तो central line निकाल दो, हो सके तो pulleys निकाल दो, drains निकाल दो, and then de-escalation of antibiotics. नहीं है ना जरूरत 3 antibiotic की, ceftriaxone, Avicas and metro. So again, I love that topic, surgical prophylaxis, antibiotics. So this is one of another checklist, again very very useful for surgeons, for doctors in daily rounds. कभी-कभी ऐसा होता है ना 5वां 6वां दिन है, हम बोर हो जाते हैं ना, ब्लॉक आ जाता है, एक मेंटल ब्लॉक, एक बर्नआउट फटीग आ जाता है फिजिशियन का, सेम पेशेंट को रोज रोज देखते देखते. So that's why if you have a checklist, then you don't miss anything. I love this book, Checklist Manifesto by Dr. Atul Gawande. He also wrote the book Being Mortal. Amazing books, amazing speaker. Please listen to his tech talk. You will love that. Yes. So he's written wonderful books. जैसे WHO में आपका pre-op checklist होता है. गॉस छूट गया, आप गॉस काउंट करते हो, मार्क करते हो.
बीच में शुरू हुआ था, ऑन द टेबल दे वो होता ना आउट टाइम इन, वो सब एनेस्थेटिक्स पहले बताऊंगी.
I so much believe that every doctor should read this book, the Checklist Manifesto.
नहीं पर अभी तो कुछ अभी तो कुछ नहीं रहता.
ये बंद हो जाता है, ऐसे ही हो जाता है.
नहीं कुछ भी नहीं है. तो जितने सारे
सर्जिकल चेकिंग में तो वो फील करना होता है, जैसे कि हमारा साइलेंट काम होता है, वहाँ पे जो होता है कि हाँ कि तो हुआ नहीं हुआ है, जो पैरामीटर्स हैं
start doing.
That's it for today. Thank you so much for your patient listening.
Thank you, Dr. Srishti. Thank you very much. I would want maybe next month or in February another talk on organ failure and organ support, because that is also very important for us, especially patients with acute pancreatitis. So
Sure.
sometime in February.
Sure. So that would be a pleasure for me. Thank you so much for inviting
Thank you.
me. Thank you, sir.